I'm Dheeraj. Uh, this is a case report of Stargardt's disease. This is a case report of Stargardt's disease. Slide not showing. Stargardt's disease is the most common form of juvenile macular dystrophy. Clinically, it is characterized by pisiform flex at the level of RPE and a bullseye maculopathy. Inheritance is usually autosomal recessive, even though some cases were autosomal dominant. Presentation: two teenage brothers came for eye examination after their father was diagnosed with Stargardt's disease, and after their father was advised to get his children screened as it was a hereditary fundus dystrophy. Patient 1, he was 18-year-old male with no ocular complaints. On examination, uncorrected visual acuity was 6.6 in both eyes, and N6 normal near vision. Color vision was normal. Anterior segment examination in both eyes were within normal limits. Fundus examination showed non-specific RPE mottling and few flecks in the parafoveal region, and rest details were normal. OCT examination showed only increased reflectivity of RPE in both eyes. Coming to the second patient, he was 17-year-old male with he had complaints of blurring of vision. On examination, visual acuity in right eye was 612 unaided, and left eye also 612. Best corrected visual acuity was 6.6 partial in right eye and 6.9 partial in left eye. Near vision was normal. Color vision was normal. Anterior segment was normal within normal limits in both eyes. Fundus examination, both eyes he had flex and flex in the parafoveal region and non-specific RPE mottling. OCT findings showed foveal thinning and irregularity at ISOS junction. Discussion: age of onset is in early teens. Visual acuity is not much affected in these cases, but progression of the disease leads to loss of central vision due to macular involvement. Treatment per se in Stargardt's disease is not specific, and visual prognosis is guarded. Patient should be counseled about repeated follow-up examination and about need for low vision aids, and also about clinical trials existing, and genetic counseling should be given. Conclusion: early diagnosis is a key factor and is required for choosing their career to prevent occupational accidents and to plan their enrollment in clinical trials if possible. Thank you.
Good evening. My poster is about electric shock retinitis. I am M. Shravani from AMC. Ocular manifestations following electric shock are rare. The most common presentation is cataract. The retinal manifestations include maculopathy, retinal blood vessel occlusions, and retinal detachments. Following is the clinical profile of one such patient. Case report: a 55-year-old female presenting with a complaint of blurring of vision since 3 days following an episode of electrocution in a domestic accident at home. On examination, the best corrected visual acuity: right eye was 6/12, left eye was 6/36. Both eyes anterior segment is normal. On fundus examination, right eye macular edema and retinitis patches between the disc and macula and flame-shaped hemorrhages around it were found. In the left eye, temporal peripapillary retinitis patches and flame-shaped hemorrhages with macular edema were seen. This is the wound site. These are the fundus images. Discussion: electric injuries can affect different tissues of the eye like extraocular muscles, cornea, retina, choroid, and optic nerve. The tissue's resistance to current and duration of exposure contributes to the pathology. Optic nerve and retina have low resistance and affected by ischemia from vascular coagulation and necrosis. The macula has high concentration of melanin in the retinal pigment epithelium, causing greater thermal denaturation and thermal energy accumulation. In addition, thermal shrinkage of vitreous can induce posterior vitreous detachment, exerting macular traction. This condition has reported to have been reversible with functional recovery. My conclusion, this study focuses on infrequent ocular complication, post-electric shock injury, and emphasizes on the importance of fundus examination, post-electric shock for early diagnosis and management, which can prevent blindness. Thank you.
My poster is today about case of foveal hypoplasia with nystagmus. A 10-year-old male Stale was brought to our OPD by his parents with complaint of defective vision and unable to recognize people since early childhood. There is no similar complaint in siblings. On examination. There is an engaged nystagmus, bilateral facial symmetry, full ductions and versions in all the gazes. Right eye vision is counting fingers 4 meters, anterior segment findings are normal and lens is clear. Left eye vision is counting fingers 3 meters, anterior segment findings are normal, lens clear. Fundus exam, both eyes shows absent foveal reflex. On OCT, foveal hypoplasia, both eyes is noted in left eye and more than right eye. We can see the foveal hypoplasia with the foveal contour abnormal. Discussion. Foveal hypoplasia is a retinal disorder where there is a lack of full development of fovea. Several diseases were known to be associated with foveal hypoplasia, which include albinism, aniridia, retinopathy of prematurity, incognita pigmenti, isolated foveal hypoplasia, and Stickler syndrome. Genetics. Mutation of PAX gene known to cause isolated foveal hypoplasia, which has an autosomal dominant inheritance. Mutations of GPR143 and SLC38A8 gene were identified to cause autosomal recessive pattern. In the above case, only poor visual acuity and absent foveal reflex and no other systemic associations are noted. These findings suggest that it is a case of isolated foveal hypoplasia with engaged nystagmus. Thank you.
Good afternoon, everyone. Today I'm going to present about a rare case report on Ross syndrome with tonic people. To our OPD, a 27-year-old female visited in the view of occasional headache, and she has history of headache since 5 days, and it was more in the evenings and release on taking rest. Patient has no history of diminution of vision, and the headache is not associated with any vomiting, syncope, or palpitations. There was no history of trauma to the head, spine, or ocular trauma, and she was not in diabetic, hypertensive, or bronchial asthma and thyroid disorders. No history of similar complaints in the past or in the family. And on ocular examination, in the right eye and left eye, best corrected visual acuity is 6/6 with near vision N6, and on slit lamp examination, anterior segment is normal in both eyes. Coming to the pupillary size, it was 3 mm in the right eye and 4 mm in the left eye, which was not reacting to the light, but on accommodation it was reacting, and the fundus is normal with the normal disc and normal foveal reflex. Coming to the systemic examination, cardiovascular, respiratory and gastrointestinal systems have no abnormalities, but neurological system shows sluggish deep tendon reflexes, and cutaneous examination shows there is hypohidrosis. And this patient was referred to the dermatologist, and opinion was taken for the hypohidrosis to confirm the case, and it shows that there is a triad of hypohidrosis, hyporeflexia and tonic pupil, which defines the Ross syndrome. This is the patient where on the on the direct light reflex there is no the pupil is not getting constricted, but on accommodation we can see the pupil getting constricted to 2 mm. And on discussion, Ross syndrome is a rare disorder which affects the peripheral autonomic nervous system, which is characterized by the triad of tonic pupils, reduced or loss of deep tendon reflexes, which is known as hyporeflexia or areflexia, and anhidrosis or hypohidrosis. This anhidrosis or hypohidrosis, which likely to occur from the degeneration of sympathetic ganglionic cells or postganglionic projections. This tonic pupil occurs from the damage to the ciliary ganglion or post-parasympathetic nervous system. Tonic pupil produces variable anisocoria, which is worse in light than in dark. The pupillary reactions shows typically impaired to the light but preserved to the accommodative reflex, which is known as light near dissociation. In conclusion, if any patient presents with an tonic pupil, we should also think about this Raw syndrome. As the patient, we have to investigate systemically to rule out other causes, to refer to the neurologist also. Thank you.
Very good afternoon to everyone. I'm Dr. Dasa Sai Pawan Kalyan from Guntur Medical College, and now I'm going to present a poster on congenital toxoplasmosis. A 20-year-old male came to the ophthalmology OPD with a complaint of low vision in both eyes since childhood. There was no history of ocular trauma or redness of the eye. On examination, the best corrected visual acuity in both eyes was only counting fingers up to 3 meters. Extraocular movements were full free, painless in all gazes. On slit lamp examination, the anterior segment appeared normal in both the eyes. This is the fundus picture of the patient. The disc was normal in size and shape, the media was clear, and the margins were distinct. And a well demarcated circular atrophic pigmented scar, which appeared to be punched out of 2 disc diameters in size, was seen in the macula in both the eyes. This is the fundus examination in brief, and the serology of the patient tested positive for Toxoplasma gondii specific IgG antibodies. So this patient was diagnosed as a congenital ocular toxoplasmosis. Discussion: this toxoplasmosis represents the main cause of infectious posterior uveitis worldwide. It is caused by Toxoplasma gondii, an epicomplex and parasite, and it occurs through vertical transmission during pregnancy. It may also occur by ingestion of contaminated meat and through water. The ocular disease presents as an active retinochoroidal lesion, which progresses to involve full thickness of the retina. Diagnosis is mainly clinical through fundus imaging and serology of the patient for IgG specific antibodies, and also PCR of the ocular fluids, namely humor, aqueous humor and vitreous. So in this above case, a well demarcated classical retinochoroidal scar involving the macula is suggestive of congenital ocular toxoplasmosis. The patient was advised yearly follow-ups. Thank you.
Good afternoon everyone. My name is Aprupa, first year postgraduate. I am presenting you a rare case on occlusive microvasculopathy, which is Kushner's retinopathy. A 28 years old male patient presented with sudden onset of painless loss of vision in both eyes, that is right eye more than left eye, since one day following head trauma due to road traffic accident. On examination, best corrected visual acuity of right eye is 5/60 and left eye is 6/36. IOP is 10 in right eye and 11 in left eye. Facial symmetry is normal. Head posture is normal. Extraocular movements are full and free in all cardinal directions. Pupil is normal in size and reacting to right. Anterior segment is within normal limits. On fundus examination, right eye, media is clear. Optic disc size, shape, color is normal. Margins are regular. Arteriovenous ratio is 2:3. Cup disc ratio is 0.2:1. Multiple polygonal patches of intraretinal whitening around the optic disc in the superior temporal and inferior temporal quadrants, and temporal to disc at the optic disc at macro area seen. Blood vessels where few retinal hemorrhages are seen in all quadrants. Foveal reflex is there. Left eye, media is clear. Optic disc size, shape, color is normal. Margins are regular. AV ratio is 2:3 and cup disc ratio is 0.2:1. One polygonal patch is present in superior quadrant and few polygonal patches are present in inferior quadrant near the optic disc. Foveal reflex is there. On visual fields, right eye central scotoma with peripheral sparing is seen and left eye is within normal limits. This is the image of right eye where we can see the thickening. So probable diagnosis is Buschner's retinopathy. Buschner's retinopathy is a very rare occlusive microvasculopathy characterized by multiple retinal white areas around the optic disc, head and fovea with paravascular clearing. May be associated with intraretinal hemorrhages. Frecking, cotton hood spots and minimal intraretinal hemorrhages are typical features. Severe vision loss either immediately or up to 48 hours after the event is seen. Vision may be decreased to 6/60 or worse and may be unilateral or bilateral. The prognosis for recovery is variable with roughly 50% of patients complaining of persisting blurred vision. No treatment is proven. Diagnosis based on the patient history, clinical presentation and laboratory workup. In the majority of cases, the ophthalmology manifestations are asymmetrical, bilateral and symptoms can be unilateral. Thank you.
Good afternoon. My name is Dr. P. Anisha. I'm going to present a case report of Vogt-Koyanagi-Harada syndrome, and my co-author is Dr. J. Rajan Prasad, sir. A 41-year-old female patient was referred to ophthalmology OPD from neurology OPD with the chief complaints of headache, dizziness, nausea, vomiting, and tinnitus since one day. She had history of on and off episodes of redness, watering, pain, and blurring of vision in both eyes since 3 years. Her best corrected visual acuity with Snellen's chart is 2/16 right eye and 3/16 left eye. Intraocular pressure measured with Goldman applanation tonometry is 11 mm of Hg in both eyes. Ophthalmic examination with slit lamp microscope and 90D lens revealed the presence of old keratic presbyrates, surgically altered pupil, pseudophakia, and bilateral exudative retinal detachment in both the eyes. She had no other disease entities or penetrating ocular trauma or previous history of ocular surgery. OCT showed serous retinal detachment in both the eyes. According to revised diagnostic criteria for weak age, she is diagnosed with incomplete weak age syndrome. She is put on treatment with IV methylprednisolone 1 gram for 3 days followed by oral steroids. She was also put on tablets Regeron 20 mg BD, tablet Vertin 4 mg BD, tablet Angsit 0.25 mg at the night time, and capsule Regenex CD3 OD. Vogt-Koyanagi-Harada syndrome is an idiopathic multisystem autoimmune disease against melanocyte-containing tissues such as uvea, skin, ear, and meninges. Early and aggressive treatment with the corticosteroids is the first choice of treatment for good visual prognosis. Immunosuppressive therapy may be required in resistant cases. Complications like cataract, glaucoma, choroidal neovascularization, retinal detachment, and subretinal fibrosis are the most common causes of visual impairment. This is OCT pictures showing serous retinal detachment in both the eyes. Thank you.
Good afternoon, everyone. My case report is a leukemic retinopathy in acute B-cell lymphoblastic leukemia. A 13-year-old female patient was brought to the ophthalmology OPD by her father with chief complaint of loss of vision in right eye since 1 month, which is sudden in onset and associated with throbbing type of headache. Patient is a known case of B-cell acute lymphoblastic leukemia since 3 months on chemotherapy. On examination, visual acuity of right eye is counting fingers close to face. Left eye visual acuity is counting fingers 4 meters. Extraocular movements are restricted in all gazes in right eye, free, full and painless in all gazes in left eye. Examination revealed mild proptosis and relative apharem pupillary defect in right eye with rest of the anterior segment being normal, and anterior segment is normal in left eye. So clinical picture of the patient showing mild proptosis in right eye. Fundus examination showed clear media with optic disc normal and vessels normal with altered foveal reflex in right eye, and the background retina in right eye showed rod spots. The fundus examination of left eye showed clear media with normal optic disc and vessels with foveal reflex being altered and subhyaloid hemorrhage in the macular region in the left eye. This is the fundus picture of right eye showing rod spots which are white centered flame shaped hemorrhages which are superior and temporal to the disc. A fundus picture of left eye showing subhyaloid hemorrhage in the macular region. Patient underwent functional endoscopic sinus surgery for fungal sinusitis and MRI showed lesion extending superiorly to the suprasellar cisternal space, encasing the right cavernous sinus and encasing the right internal carotid artery with associated thrombosis, which might be the possible explanation for the restriction of extraocular movements and proptosis in the right eye. Discussion: leukemia is a myeloproliferative disorder caused by abnormal proliferation of immature leukocytes. Ocular manifestations of leukemia are caused either as primary involvement by direct infiltration of leukemic cells or secondary involvement as a result of hematologic disturbances including thrombocytopenia and anemia. Retina is the most common ocular tissue to be involved in leukemia. Most obvious observations are retinal hemorrhages at all levels, which are most typically located in the posterior pole, such as preretinal, superficial retinal hemorrhages, subhyaloid or white-centered hemorrhages also known as rod spots. These white centers are made up of leukemic cells, capillary emboli or cellular debris. Conclusion: management approach of ophthalmic manifestations in leukemia involves interdisciplinary cooperation and should be individualized on the basis of patient's underlying medical condition. Thank you.
Good afternoon everyone. Myself Dr. Nikita. I'm here to present a case of granulomatous chorioretinitis in systemic tuberculosis. Tuberculosis is a clinical disease caused by infection with Mycobacterium tuberculosis and is characterized pathologically by formation of a granuloma described as systemic disease of protein manifestation that mainly involves lung. Extrapulmonary involvement includes lesions of gastrointestinal tract, genitourinary tract, cardiovascular system, skin, central nervous system and eyes. It may occur in association with clinically apparent pulmonary TB. India ranks first in contributing 80% of world's total burden of tuberculosis. The delay in diagnosis can be due to the fact that clinical signs simulate any other inflammatory disease. The diagnosis is usually based on tissue examination in histopathological evidence presenting as granulomatous lesion with presence of acid-fast bacilli. A 22-year-old female came to Regional Eye Hospital, Kurnool with complaints of gradual loss of vision associated with pain in right eye since 1.5 years. On general examination, everything was within normal limits. Systemic examination was normal. Past history was chronic cough since 1 year. On ocular examination, vision was with Snellen's movements in left eye 6/6. Other anterior segment findings were within normal limits. Extraocular movements were full and free in all gazes in both eyes. On fundus examination, in right eye, media was clear. Optic disc was hyperemic with blurred margins surrounded by multiple hard exudates. Cup disc ratio could not be accentuated. Blood vessels, generalized arteriolar attenuation was present. Venous engorgement was present. Macula, a hypopigmented lesion, 3 disc diopters temporal to optic disc, measuring approx 5 disc diopters in macular area is noted. Left eye fundus examination was within normal limit. Investigation: B scan was normal. ESR and CRP were elevated. HBsAg, HIV, HCV and rheumatoid factor was 25 mm positive. CB nat was positive. This is the fundus picture. Discussion: the prevalence of extrapulmonary TB among new and relapsed TB cases globally in 2016 was 15%. Tuberculosis of orbit is extremely rare, even in places where tuberculosis is endemic. The literature on orbital tuberculosis management is dominated by case series and case report. In this patient, which presented with gradual progressive loss of vision in right eye, on complete examination we found granulomatous lesion in right eye with Montauk's test positive, CB nat positive. Conclusion: of intraocular TB may have varied presentation including choroidal tubercle, choroidal tuberculoma, subretinal abscess, retinitis and retinal vasculitis, neuroretinitis, optic neuropathy, endophthalmitis and panophthalmitis. Several clinical signs too have been described, namely posterior synecdoche, retinal vasculitis with or without choroiditis, and serpiginous like choroiditis. Thank you.
Good afternoon, everyone. My name Manasa. My topic is retinitis punctata albicans. Introduction. The term atypical retinitis pigmentosa has been conventionally used to group together heterogeneous disorders, clinically having features in common with atrophy. There are two forms of congenital stationary night blindness associated with abnormal fundi, fundi albipunctatus and Oguchi disease. Both exhibit autosomal recessive inheritance. A case report, a 23 years old man presented with chief complaint of diminution of vision in both eyes, which is gradually progressive, painless for 15 years, associated with night blindness, using spectacles for past 15 years. Third product of consanguinity with no significant family history of night blindness. Visual acuity is 4/60 in both eyes with pinhole 6/60. Best corrected vision is in both eyes 6/12. Investigations, fundus ophthalmoscopy, whitish yellow spots present all over the fundus, sparing macula, arteriolar attenuation present in both eyes, OCT is normal, visual fields shows peripheral archiform defects, ERG some irregular morphology potentials, collecting the and B waves increased both in photopic and scotopic conditions. VEP showed a regular morphology with wave latency peaks and amplitudes within the normal limits. This is the fundus picture showing whitish yellow spots all over the fundus, sparing the macula. Management, there are currently no specific treatment available for congenital stationary night blindness. A non-randomized study in which an alternative source of chromophore, 9-cis beta carotene, was given orally to patients with fundus albipunctatus showed significant improvement in automated static visual field mean deviation. Photoreceptors replacement by transplantations and gene therapy are modalities under investigations. Discussion, retinitis punctata albicans is a type of atypical retinitis pigmentosa. It is a autosomal recessive and dominant characterized by the scattered whitish yellow spots, sparing macula and associated with the arteriolar attenuation. Individuals complain of the night blindness or a delayed dark adaptation from childhood. Visual acuity and color vision are usually normal. Visual prognosis depends on macular atrophy, which is usually progressive. Conclusion, the case presented is rare. The diagnosis is based on test. Study can be carried out to characterize the damage as well as possible complications. Thank you.
Good afternoon, everyone. My topic is visual prognosis in post-traumatic sclerolimbal laceration with iris and vitreous prolapse. Aim of the study is to report prognosis related to visual outcome in sclerolimbal laceration with vitreous in the wound site of an open globe injury. Methodology includes it is a prospective interventional study of an individual with deep sclerolimbal laceration with iris and vitreous prolapse at the wound site. Preoperative evaluation done under slit lamp and CT scan and MRI are done to rule out any fractures and impacted foreign bodies. Under strict aseptic conditions and antibiotics coverage, wound was explored under local anesthesia. A deep laceration of 6 mm length involving full thickness sclera and limbus at 5 o'clock position, which was sealed by conjunctiva, noticed with iris and vitreous prolapse. Iris abscission and vitrectomy done, sutured with 10-0 nylon at limbus and sclera with 6-0 vehicle. These are the pictures showing sclerolimbal laceration. Results on post-operative day 1 showed shallow but formed anterior chamber with iris peaking. Sutures were intact with surrounding conjunctival chemosis and hemorrhage. Post-op day with mild conjunctival congestion and decreased periorbital edema. Intact sutures with no evidence of inflammation or infection. Follow-up done every 2 weekly up to 3 months, and also this patient underwent surgery for cataract after 4 months of sclerolimbal repair. Post-op 7 days vision showed 624. Discussion part. Lacerations extending beyond the limbus and into sclera anterior to the equator, which are less deep, show better visual prognosis, but care to be taken at every step to prevent iatrogenic damage or further extrusion of intraocular contents. Wound boundaries should be carefully explored. Foreign bodies checked also for vitreous and uveal prolapse. Vitreous is cut flush with sclera to prevent traction on vitreous, and uveal prolapse corrected by hand over hand technique with interrupted sutures, meanwhile depressing the uveal tissue. Ocular trauma also causes cataract incidence, angle recession, which should be taken care of. Conclusion. Early and prompt intervention like thorough evaluation including careful and detailed slit lamp examination, Seidels test, early wound exploration and repair, maintaining globe contour with appropriate treatment post-operatively to prevent endophthalmitis and sympathetic ophthalmitis yields better visual outcome. Thank you.
Good afternoon. A case report of breast macular dystrophy. An 18-year-old female who presented to our ophthalmology OPD in May 2023 for visually challenged certificate. Her best corrected visual acuity in right eye with minus 1.5 diopter spherical is 5/60 and near vision is N24. And coming to the left eye with minus 0.25 diopter spherical is 6/9 and near vision is N8. Anterior segment of both eyes is normal. Extraocular movements are full in both eyes. Coming to the fundus examination, both eyes, media is clear and optic disc size and shape are normal and margins are distinct. Cup disc ratio is 0.3:1 and vessels are normal. Coming to the macula, appearance of horizontally oval dot and halo lesion of approximate 1.5 disc diopter size centered on the fovea. This is the fundus picture. And coming to the B scan of both eyes within normal limits, and OCT there is bilateral foveal thinning. And coming to the electroretinogram within normal limits and electrooculogram subnormal with the decrease in Arden ratio of 1.4. Coming to the discussion, breast macular dystrophy is a congenital autosomal dominant condition caused by mutation in BEST1 gene, that is increased RPE lipofuscin, loss of receptors and sub-RPE drusenoid material accumulation of cells and material in subretinal space with scrambled egg lesion at macula, that is typically solitary, round or horizontally oval, yellow, slightly elevated and are centered on fovea. These may be smaller or larger lesions, and patients may develop hyperopia type of refractive error in advanced cases. Coming to the conclusion, in the above case, on excluding other congenital anomalies of macula like Stargardt's disease, that is having typically light colored flecks all over the fundus, and North Carolina macular dystrophy, circular coloboma centered on fixation with concave base surrounded by thick and fibrotic rim, and pattern dystrophy which shows butterfly shaped pigmentation. This case was diagnosed clinically as bilateral breast macular dystrophy in atrophic stage, more in the right eye. Thank you.
Good evening everyone. Today I am here to discuss about a case report of familial exudative vitreoretinopathy. Introduction. Familial exudative vitreoretinopathy is a group of inherited retinal disease characterized by abnormal retinal angiogenesis leading to incomplete vascularization of the peripheral retina with subsequent retinal ischemia. Familial exudative vitreoretinopathy is a genetically heterogeneous disorder that exhibit variable penetrance across patient. Expressivity may be asymmetric and highly variable. 5 genes have been identified: NDP, FZD4, LRP5, TSPAN, and ZNF408 gene has been identified in the pathogenesis of familial exudative vitreoretinopathy. The purpose of the study is to study about a retrospective case report of familial exudative vitreoretinopathy. A 36-year-old female who was a diagnosed case of familial exudative vitreoretinopathy elsewhere has come to the outpatient department of ophthalmology for disability certificate. 2 years back, she had diminution of vision which was sudden in onset. Her best corrected visual acuity in her right eye is counting finger half meter, and in her left eye it was 6.6. On slit lamp examination, both eye appears to be normal. Fundus photograph of the patient shows the following. Right eye shows retinal fold and dragged macula extending up to the optic disc and straightening of blood vessels present, and left eye shows normal fundus finding. The fundus photograph of the right eye shows dragged macula which is extending up to the optic disc area, and there is straightening of the vessel, and in the right eye and in the left eye the fundus shows a normal fundus finding. The patient received anti-VEGF treatment twice, and retinal photocoagulation was done. Patient was advised for further follow-up for future complications like retinal detachment, and visual prognosis was explained. So my conclusion is familial exudative vitreoretinopathy is a heritable vitreoretinopathy characterized by anomalous retinal vascular development. The prognosis for infant with FEVR is extremely poor, and the long-term prognosis for patient with a later onset of this condition is guarded. Retinal detachment, macular dragging, and cataract are common late complications which can develop even in patient whose eye findings appears to be stable. Since the patient came with the advanced stage with fibrovascular band, the prognosis of this patient is very poor. Thank you.
Good afternoon, everyone. I'm Dr. Lakshmi Sharma, giving my poster presentation on the topic neuromyelitis optica. Neuromyelitis optica spectrum disorder, traditionally known as neuromyelitis optica or Devick's disease, is a rare autoimmune, inflammatory, and demyelinating disorder of CNS, which is characterized by attacks of acute optic neuritis and transverse myelitis. Approximately 75% of patients have antibodies against aquaporin 4, a water channel expressed on food processes of the astrocytes. NMO-SD consists of standard NMO, Asian optic spinal multiple sclerosis, association of systemic autoimmune diseases, anti-myelin oligodendrocytes glycoprotein, and other neurologic manifestations that may be associated with MRI abnormalities. Clinical signs and symptoms of NMO are similar to those of multiple sclerosis but differentiated by its increased disability related to relapses. Its prevalence is 13.7% among all demyelinating disorders in India, and in southern India is 2.7 per 1 lakh people. In acute illness, considerable recovery achieved with steroids and plasma exchange. Immunosuppressants are helpful in relapse prevention. A middle-aged male presented to the Department of Ophthalmology, SVRR-GGH, having no comorbidities, with the blurring of vision in both eyes, left eye more than right eye, since 10 days with no pain on extraocular movements or double vision. On investigations, on examination, vitals are stable and reduced visual acuity seems in left eye with counting fingers close to the face. Anterior segment examination revealed left eye RAPD. Color vision showed red desaturation in left eye. Fundus examination revealed both eye temporal pallor of the disc. CBC was within normal limits, and serum NMO antibodies, aquaporin 4 IgG, was strongly positive. MOG antibody status was unknown due to financial concerns of the patient. Visual fields, right eye normal study, and left eye shows constriction of peripheral fields. CSF analysis showed 6 lymphocytes, glucose level 113 mg per dl and protein 31 mg per dl. VEP depicts a prolonged P100 latency of 165 milliseconds in left eye, suggested of left eye anterior optic pathway conduction defect. OCT shows thinning of the retinal nerve fiber layer in the left eye. MRI brain and whole spine was normal, An MRI orbit showed evidence of hyperintense T2 flare signal noted in the optic nerve with abnormal enhancement noted in bilateral retrobulbar portion of the optic nerve with thickening of the optic nerve noted suggestive of bilateral optic neuritis. So OCT revealed the retinal nerve fiber layer thinning, and VP shows in the left eye prolonged P100 latency. We asked a neurology opinion for this case, and they confirmed the association of bilateral optic neuritis correlated with the above mentioned investigation findings suggestive of neuromyelitis optica. We started treatment for optic neuritis with IV methylprednisolone 1 gram daily for 3 days, followed by oral prednisolone 1 milligram per kg per day daily, and then tapered for 4 days. During the follow-up period of 2 months, visual acuity came to right eye BCVA 6/9 and left eye 6/6. Anterior segment became normal, color vision was normal. He was not cooperative for the visual fields at that time. So on the basis of above investigations and evaluation, diagnosis of NMO was made. Discussion. NMOSD is a severe autoimmune inflammatory disorder of CNS presenting as a monophasic or relapsing disease that predominantly targets the optic nerve and the spinal cord. Diagnostic criteria for NMSD with the aquaporin 4 IgG requires at least one core clinical characteristic with a positive test for aquaporin 4 IgG using the best available detection method. Diagnostic criteria for NMOSD without aquaporin 4 IgG or with unknown aquaporin 4 IgG status requires at least two core clinical characteristics occurring as a result of one or more clinical attacks. It means at least one core clinical characteristic must be optic neuritis, acute myelitis with the LATM, area post-tremor syndrome, or acute myelitis syndrome. Dissemination in the space, fulfillment of additional MRI requirements. In this case, absence of detectable lesion in MRI spine questions the diagnosis of NMOSD. So early diagnosis and prompt management with aggressive immune modulation is indicated. Thank you.
Good evening everyone. Myself Dr. Lekha, and I'd like to present about diabetic papillitis, understanding a rare ocular complication. Diabetic papillitis, also known as diabetic papillopathy, is a relatively uncommon but significant ocular complication that occurs in individuals with diabetes mellitus. It affects the optic nerve head, which is crucial for transmitting visual information from retina to the brain. This condition is characterized by inflammation and swelling of the optic disc, resulting in a range of visual disturbances and potential vision loss. As the prevalence of diabetes continues to rise globally, understanding this diabetic papillitis has become increasingly essential. This condition poses unique challenges to healthcare professionals due to its similarities with other optic disc disorders, making the accurate diagnosis and timely intervention crucial to prevent the further complications. A 36-year-old female patient has presented to our OPD department with complaints of diminution of vision in left eye for 1 week, which was sudden in onset and progressive and also associated with headache. Patient is a known case of diabetes mellitus for 9 years and is on regular medication. There was no history of hypertension and cardiovascular disease. Ophthalmic examination revealed best corrected visual acuity in right eye of 6/9 partial and left eye of 6/12. On swinging flashlight test, relative afferent pupillar defect was detected in the left eye. Slit lamp biomicroscopy revealed vitreous liquefaction in the right eye. These were the fundus photographs, and the left eye showed an 2-diopter elevated edematous disc with blurring of all the disc margins, and also both eyes showed moderate non-proliferative diabetic retinopathy changes. Non-contact tonometry revealed IOP of 17.3 in the right eye and 17 mmHg in the left eye. Metabolic workup revealed deranged glucose metabolism with FBS of 192.95 and postprandial blood sugar of 282.09 milligram per deciliter. Coming to discussion, diabetic papillitis can be observed in individuals with both type 1 and 2 diabetes mellitus with an estimated incidence of around 0.5%. Although its pathophysiology isn't fully elucidated, it is believed to be associated with diabetic microangiopathy, which finds some support in abnormal disc surface staining and fluorescent leakage observed on fluorescent angiogram. Patients with diabetic papillitis typically exhibit mild degrees of diabetic retinopathy. This suggests that diabetic papillitis is considered a distinct condition rather than being considered merely an extension of diabetic retinopathy. The currently accepted criteria are confirmed diagnosis of diabetes mellitus, optic disc edema, absence of significant optic nerve dysfunction, normal intracranial pressure, and absence of nerve inflammation, infection, or infiltration. Studies have shown that in patients with diabetes who initiate intensive insulin treatment, the incidence of diabetic papillitis has been linked to a failure to downregulate retinal blood flow and a tendency towards increased retinal perfusion. The differential diagnosis includes papilledema, neuroretinitis, infiltrative optic neuropathy, compressive optic neuropathy, AAION and NAION. Coming to management, as of now, there is no established therapy that has been validated for diabetic papillopathy. In most cases, the disc swelling typically resolves spontaneously within 4 to 8 weeks. However, in certain situations, intravitreal corticosteroids or anti-vascular endothelial growth factor therapy might be recommended. Conclusion. In summary, it is essential to consider this diabetic papillopathy as a potential differential diagnosis of papilledema in diabetic patients who exhibit apparent papilledema, but only after diligently ruling out the intracranial pressure increase. Thank you.
Good evening, myself Dr. Suhasini, and today my poster presentation is a case report on unilateral thyroid eye disease with euthyroid status. Introduction. Proptosis is the forward protrusion of the eyeball beyond the orbital margins. Thyroid eye disease is a self-limiting with active and static phases. Exophthalmos is the term restricted to thyroid eye disease, and it occurs in 20 to 30% of patients with Graves' disease and 40 to 70% of patients with thyroid eye disease. Pathological changes affect both extraocular muscles and fat compartments. Orbital imaging usually CT shows a tendon sparing enlargement of the muscle, which clinches the diagnosis. Management depends upon the Ugogos grading. A case report on thyroid eye disease. A female patient present to our OPD department who is 58-year-old with complaints of forward protrusion of the eye since 3 years. Forward protrusion is confirmed by exophthalmometry. On slit lamp examination, both eyes for inferior scleral show. On lid sign shows Enrod sign, which is fullness in the eyelid, vigorous sign pigmentation of the eyelids, Mobius sign deficiency in convergence or positive in the right eye. Extraocular movements on examination are restricted in superior and lateral gaze. Force detection test was conducted which showed restriction superiorly and laterally. Differential intraocular pressure showed a major difference. BCVA was 6/9 with near vision N6 in both eyes. Color vision and contrast sensitivity are normal. Fundus examination is also normal. And nose specs score was 4 and clinical activity score was 1. Thyroid profile was normal. CT showed a tendon sparing bulky lateral rectus. Patient started on conservative management and advised to follow up. These are the pictures of patient showing unilateral right eye proptosis. And Lutz exophthalmometer showed 24 mm in measurement. CT showed a tendon sparing muscle enlargement. Thank you.
Good evening everyone. I am Dr. Divya. My topic for today's poster is an interesting case report of retinoblastoma. Retinoblastoma is a rare eye tumor of childhood that arises in the retina and represents the most common intraocular tumor malignancy of infancy and childhood. Incidence is 1 in 15,000 to 20,000 live births and accounts for 3% of all childhood cancers. Approximately 60% cases are unilateral and 40% are bilateral. Case report. A 2-year-old male child assisted by parents came to the hospital with the complaints of abnormal white pupillary reflex seen in the left eye since 1 year of age. Child was initially taken to a peripheral eye institute regarding the same complaint. He was examined at the institute and referred to us for MRI scan. Examination. Head posture is normal. Facial symmetry is maintained. On ocular examination in eyelids, no abnormality is detected. Conjunctiva is quiet in both eyes. Cornea is clear. Anterochamber is within normal limits in right eye and deep and quiet in left eye. Pupil is round, regular and reacting in right eye, and round, regular white reflex is seen in left eye. Hirschberg's corneal test is central in right eye and mild ESO deviation is present in left eye. Extraocular movements are full and free. Fundus examination with mediatric and examination under anesthesia with indirect ophthalmoscopy revealed endophytic elevated lesion that extends less than 50% of retina. MRI report showed space occupying lesion along posterior surface of vitreous and vitreous detachment, most likely to be retinoblastoma on the left side. Tumor is classified as group C in ICRB and stage 2A in Ellsworth classification. Patient is managed with chemotherapy with carboplatin, etoposide and vincristine. Discussion. Retinoblastoma most commonly presents with leukocoria and strabismus. So all children presented with strabismus should be screened with fundoscopy. Retinoblastoma must be differentiated from persistent anterior and posterior fetal vasculature, Coats disease, retinopathy of prematurity, uveitis and vitreoretinal dysplasia. It is classified under Rees-Ellsworth classification and ICRB classification. Management includes chemotherapy with carboplatin, etoposide, vincristine, transpupillary thermal therapy, cryotherapy and brachytherapy. Enucleation is a definitive treatment and is generally indicated if there is neovascular glaucoma, anterochamber infiltration, optic nerve invasion, or if tumor occupies more than half of vitreous volume. Conclusion. Retinoblastoma must be considered in the differential diagnosis for any intraocular disease due to importance of early diagnosis and management. Management of retinoblastoma should be aimed to preserve the life first and then sight of the affected child. It is managed by multidisciplinary approach which includes ophthalmologist, oncologist, pediatrician, pathologist and radiation therapist. Siblings at risk of retinoblastoma should be screened by prenatal ultrasonography and by ophthalmoscopy soon after birth and then regularly until the age of 4 or 5 years. Thank you.
Good afternoon everyone. I am Dr. Bhavya, first year postgraduate. I will discuss about a case on serpentine lesions on fundus. To begin with, serpiginous chorioretinopathy is a rare bilateral idiopathic inflammatory disorder of retinal pigment epithelium, retina and choriocapillaries. The age distribution is between 30 to 60 years with slight male predominance. Increased frequency of HLA-B7 is seen in these cases which indicative of an inflammatory process. They are characterized by multiple recurrences, often asymptomatic until the fovea is involved. Where fovea is involved, they have painless blurry vision and central or paracentral scotomas. These are of two types, classic and macular. In classic type, comprises mainly of 80% of cases with bilateral asymmetric serpiginous lesions starting at the peripapillary region and they can extend up to the macula. In macular type, involves the macula and space the peripapillary region. My case report, a 42-year-old male patient presented with a history of central blurry vision since several months. There was no significant past medical or ocular history. His best corrected visual acuity was 6/9 in right eye and 6/36 in left eye. Anterior segment examination was unremarkable. Fundus photography and optical coherence tomography are performed for this diagnosis. Fundus picture. Fundoscopic examination revealed finger-like projections of yellow-gray chorioretinal lesions extending from the optic disc to the macula with the involvement of the parafoveal region in the right eye, and the similar chorioretinal lesions seen in the left eye, where sparing of the fovea is seen in the left eye. OCT picture revealed the lesions affecting outer retinal layers and choriocapillaries and appear as increased reflectivity localized to the outer retina and disruption of photoreceptor bands are seen. My differential diagnosis: acute posterior multifocal placoid pigment epithelopathy, APMPPE, where lesions clinically appear similar to that of the active serpiginous chorioretinopathies, but typically multiple discrete and plague-like appearance is seen. Tuberculosis also causes serpiginous-like choroiditis, where multifocal lesions involving the periphery rather than peripapillary region was seen. Treatment: patient was started on oral prednisolone 60 mg per day. The active lesions showed improvement and a few steroid stabilizers for regular follow-ups, and referred to general medicine department for immunological workup. My conclusion: early diagnosis and prompt treatment of this type of rare lesion should be made effective. Although the prognosis of serpiginous chorioretinopathy is poor, complications of the disease should also be addressed. Thank you.
Good afternoon. I'm Dr. Ajay Matthews. My poster is on a case of HIV retinopathy. A 40-year-old male patient who is a known case of recently diagnosed HIV positive, complaining of vomiting, fever, headache, and seizure-like activity. Since 1 week came to our ophthalmology OPD as a referral from medicine OPD. Right eye visual acuity 6/6, left eye visual acuity 6/6. Extraocular movements in both eyes are free, full, and painless in all cases. On slit lamp examination, both eyes, anterior segment, no abnormalities detected, pupil normal in size and reacting to light, lens clear. Fundus examination shows a clear media with optic disc normal in size and shape with distinct margins, cup disc ratio of 0.3:1. Foveal reflex is dull in both eyes. Background showing hypopigmented spots which are present along the arcades and surrounding the optic disc. These are the fundus images showing cotton wool spots. HIV retinopathy is the most common ocular manifestation of HIV, which is seen in 40% to 60% of patients, which are associated with low CD4 counts. It is usually asymptomatic with fundus picture showing cotton wool spots and can be associated with intraretinal hemorrhages and microvascular changes like microaneurysms and telangiectasias. Pathophysiology of HIV retinopathy can be due to immune complex deposition, increased plasma viscosity, or invasion of vascular endothelium by HIV. Differential diagnosis: interferon retinopathy, radiation retinopathy, diabetic retinopathy, hypertensive retinopathy, intraocular lymphoma, SLE, polyarteritis nodosa, or cat scratch disease. Conclusion: in the above case, patient was recently diagnosed with HIV with no significant visual symptoms. Slit lamp examination and fundus examinations findings were all suggestive of a case of HIV retinopathy. The patient was advised for regular follow-up with CD4 counts and to continue his antiretroviral therapy treatment. Thank you.
Good afternoon. Good afternoon, everyone. My papato is it scared or scared fundus? A 60 years old female patient presented with painless loss of vision in left eye since 15 years. Vision of left eye is counting fingers and had a history of one intravitreal injection to her left eye 15 years back. Methods data collected was history, clinical features, fundoscopy examination and OCT. In fundoscopy examination reveals diffuse scarred chorioretinal atrophy around optic disc with pigmentation. Disciforms are fibrovascular skull involving the choroid, retinal pigment epithelium and sensory retina is the end stage of CNVM. It is white or yellow in color with pigmentary changes. In OCT, we see diffuse thinning of the macula. CNVM, choroidal neovascular membranes are new damaging blood vessels that grow beneath the retina. These blood vessels grow in an area called the choroid. They break through the layers of Bruch's membrane and penetrate the retinal pigment epithelium and grow under neurosensory retina. It can cause severe visual loss due to leakage, hemorrhage and scar tissue formation, damaging the photoreceptors and retinal pigment epithelium. Differential diagnosis: high myopic fundus, white dot syndrome, serpiginous choroidopathy. Conclusion: scarred CNVM is the most common cause for chorioretinal atrophy in elderly patients. Thank you.
Good evening, everyone. My case report of Eales disease. Purpose: to report a classical case of Eales disease. Introduction: Eales disease is an idiopathic occlusive vasculitis involving the mid-peripheral retina. It is characterized by retinal venous inflammation, that is periphlebitis, vascular occlusion, and subsequent retinal neovascularization. It commonly affects the age group of 20 to 40 years, affects males more than females. It is most commonly bilateral. It is uncommon in pediatric population. A hallmark feature of Eales disease is recurrent vitreous hemorrhage. Case history: a 25-year-old male came to outpatient department of ophthalmology with floaters and decreased vision in both eyes. Patient is diagnosed with respiratory tuberculosis 2 months back, and currently patient is on ATT. Visual acuity: CF 3 meters in both eyes, and it is not improving with glasses. This is a fundus picture showing vitreous hemorrhages in both eyes. Conclusion: Eales disease is a diagnosis of exclusion, and one should ensure a proper history, examination and investigations are conducted to exclude other likely differentials. A possible link to previous exposure to tuberculosis and hypersensitivity to tuberculin protein has been suggested as well as seen in this report. Moreover, extensive retinal ischemia might lead to the unusual presentation of Eales disease as neovascular glaucoma. A highly immunogenic protein is translated by the MPT64 gene in Mycobacterium tuberculosis. PCR for this gene has been diagnostically used successfully. Diagnostic procedures include fundus fluorescence angiography, B-scan, and optical coherence tomography. Medical treatment includes steroids, immunosuppressants, and ATT for active TB. Laser photocoagulation is the treatment of choice in Eales disease with proliferative stage. Surgical treatment includes pars plana vitrectomy in cases with persistent vitreous hemorrhage. Prognosis: it carries good prognosis with proper treatment. Thank you.
Good afternoon, everyone. My topic for today is a rare case of bilateral X-linked retinoschisis. X-linked retinoschisis is a rare congenital condition of the retina which is due to the mutation in the gene RS1 particularly which encodes for retinoschisin pigment, a protein that has been involved in intercellular adhesion and retinal cellular organization. The prevalence of this disease is somewhere about 1 in 15 to 30,000, and it is one of the main cause for juvenile macular degeneration in males. It is characterized by symmetric bilateral macular involvement beginning in the first decade of life, and most affected individuals are males, as heterozygous females will rarely be affected and remain as carriers. So case report, a 27-year-old male patient presented to the Department of Ophthalmology with headache, blurring of vision, and which is gradually progressive for the past 15 years. There is no history of consanguineous marriage in the family, but his maternal grandfather had similar complaints at 50 years of age. His parents and siblings were normal. On examination, he had a visual acuity in the right eye of 6 by 24 with pinhole no improvement, and left eye 6 by 24 with pinhole 618. The color vision was normal, peripheral vision was normal, and on fundus examination, it showed bilateral symmetrical foveal schisis with spoke wheel pattern radiating from the foveal area. So there was spoke wheel pattern from the foveal area, and fundus autofluorescence highlights the area of foveal schisis, and OCT shows cystic-like spaces in the foveal and the parafoveal areas. So mainly this patient was administered with carbonic anhydrase inhibitors for the foveal schisis and was asked for a follow-up period after 6 months, and he was counseled about the patients this patient will transfer the disease not to the sons but to the grandsons. So that has to be educated, and he has to be avoided for direct head injuries, as it may trigger retinal detachment. Thank you.
A case report of Axenfeld anomaly associated with foveal hypoplasia and nystagmus. Introduction. Axenfeld-Rieger syndrome refers to an autosomal dominant genetic condition characterized by anterior segment dysgenesis and systemic abnormalities. Axenfeld anomaly is a condition where the Schwalbe's line is displaced and prominent, also called posterior embryotoxon. Rieger anomaly characteristically presents with central iris defects such as irregular pupils with stromal hypoplasia. Rieger syndrome describes patients with Rieger anomaly in addition to systemic features. Case report. A 32-year-old female presented to ophthalmology OPD of GMC Srikakulam with complaints of diminution of vision in both eyes since childhood. Gradually progressive visual loss. Vision was profoundly decreased by the age of 15 years. No other history present. Non-consanguineous marriage. No significant family history present. General systemic examination normal. Facial symmetry normal. Head posture normal. Extraocular movements full and free in all directions. Horizontal nystagmus is present. Visual acuity, counting finger close to face, not improving with glasses. On anterior segment examination, right eye, eyelids normal, conjunctiva quiet, cornea clear, anteriorly displaced prominent Schwalbe's line, present temporarily, extending from 7 o'clock to 12 o'clock position. Anterior chamber normal depth and condensed, iris normal color, thick iris strands extending from pupillary border towards periphery of cornea at 7 o'clock, 10 o'clock and 3 o'clock position. Pupil normal size reacting to light, lens clear, gonioscopy prominent Schwalbe's line present with thick iris strands extending to Schwalbe's line, able to see scleral spur through the strands. IOP 18 millimeters of mercury. Left eye, eyelids normal, conjunctiva quiet, cornea clear, anteriorly displaced prominent Schwalbe's line present nasally extending from 6 o'clock to 12 o'clock position. Anterior chamber normal depth and condensed, iris normal color, thick iris strands extending from pupillary border towards periphery of cornea 2 o'clock to 5 o'clock position. Normal size and reacting to light, pupil, lens clear, gonioscopy prominent Schwalbe's line with thick iris strands extending to Schwalbe's line, able to see scleral spur through the strands. IOP 90 millimeters of mercury. Fundus both eyes, media clear, optic disc normal, CDR 0.6:1, vessels normal, AV ratio 2:3, foveal reflex absent, and OCT picture also shows foveal hypoplasia. Diagnosis: Axenfeld anomaly with foveal hypoplasia and nystagmus in both eyes. Conclusion: Axenfeld anomaly is a rare eye disease with major visual complications. About 50% of cases evolve with glaucoma. Therefore, the importance of early diagnosis, follow-up, and adequate treatment becomes evident to preserve the visual function of the patient. Thank you.
A case report of coloboma of iris and choroid. Purpose of the study is to study a case of coloboma of iris and choroid. Introduction. Ocular coloboma is caused by defective closure of the embryonal fissure. The occurrence of coloboma can be sporadic or hereditary. The genetic basis for occurrence of coloboma appears to be complex. It can occur in isolation or occur with systemic abnormalities. Coloboma associated with chromosomal aberrations are more likely to have systemic abnormalities. Isolated coloboma can be sporadic or familial. Mutations in genes SHH gene, PAX2, PAX6, VAX, etc. develop coloboma. Case report. A 12 years old male patient came with the complaint of defective vision which is gradually progressive. On examination, his best corrected visual acuity of right eye is counting fingers 1 meter, left eye is counting fingers 3 meters. There is keyhole defect of iris on anterior segment examination. On direct ophthalmoscopy, there is coloboma of choroid involving optic disc right eye, coloboma of choroid left eye. This is a picture showing keyhole defect on anterior segment examination. Conclusion. Early recognition of these cases will improve parents' understanding as well as genetic counseling. We also recommend lifelong follow-up for coloboma cases to catch up any retinochoroidal changes or development of cataract and glaucoma. Thank you.